from Suresh. Suresh, read
Teacher.
the next 30 years old woman.
Teacher,
Yes,
Yes.
can you repeat the explanation for last question? We couldn't hear because internet.
Last question, yes. Last question, it is high perineum, yeah?
Yeah.
Yes, guys, it's very easy. Now imagine very high perineum, and it is as obstacle for birth of the fetus head. When the fetus head is on the pelvic floor, it is the end of the. Так, Shanil Kaushal, I see, yes. Kaushal, come to us, yes. Is on the pelvic floor. This perineum is very thin, is very high. Yes, high, it is no thick, more than 4 centimeters. You know what does it mean, this space perineum? Yes, it is obstacle for labor. And we need to perform episiotomy. Yes, a section of the vulva on the left or right side from the perineum. Yes, more better to do this incision. We will speak about it on the class. We have, to my mind, investigation of the fetus, and next will be obstetric operation, where we discuss this topic about the obstetric operations. Perineotomy we make if begin rupture of the perineum. If there is no rupture and only risk of perineum, we perform episiotomy. Perineum more than 4 centimeters. If you see in KROK test 4 centimeters perineum, usually you need to choose episiotomy. It is as a keyword. It means that it is high perineum, and it's maybe obstacle for further birth of the fetus head. Understand, guys?
Yes. Thank you.
Yes. Please, Suresh,
yes, teacher.
read the test. Number
A
3.
30-year-old woman is in her second labor that has been lasting for 14 hours. Fetal heartbeats are muffled, arrhythmic, 100 per minute. Vaginal examination results cervical dilation is complete. Fetal head is close to the exit of small pelvis. Sagittal suture has the direct diameter. Small crown is close to the pubis. What is the further tactic of management? Is the use of obstetric forceps.
Yes, guys, I want to see it is anomalies. Yes, why we need to use in this case? What is the indication for using of forceps, and why not, for example, labor stimulation or cesarean section or use of cavity forceps? You see here use of obstetric forceps and cavity forceps. Again, provoked question. Again, the same forceps. It seems. Yes. No, at all, I don't like this option. They need to write here use of low forceps or use of outlet forceps. It's more better to say. But now, why we need to use the forceps? Can you explain me, Suresh?
Yes, teacher. Teacher, the labor is like already it has been 14 hours and the cervical dilatation is complete, and the fetal head is also in the almost exit, but it cannot come out. So hence there is fetal head, like heartbeat is getting muffled and it is difficult for the fetus. So we help it by obstetrical force.
No, guys, my dear, you name everything. First of all, indication for this forceps, guys. We have conditions for applying forceps and indications for applying forceps. And in this test, they give you the indications. Indications for applying, it is what? What are the main?
Fetal heartbeat.
It is what? It is bradycardia.
Yes.
Arrhythmia, muffled, 100 in a minute. It is severe bradycardia because we have arrhythmia, yes, together. You know that normal it is 120 to 160 fetal heart beating. Acceleration, if we see more than 160, it is the sign when the fetus can compensate hypoxia. It is also distress of the fetus, but acceleration means the fetus heart work more quickly and compensate this less of oxygen which appear. Yes, distress. First of all, it is the decrease of the level of oxygen in blood. Yes, if we have bradycardia, it is decompensation. And our reaction of the doctor need to be immediate, yes, to this condition. And they give you, it is indication for apply. Condition, you know that they gives you, you see, they gives you cesarean section maybe, yes. But why we choose forceps, guys? Why we choose forceps? We need to have for these conditions. What conditions we have? Complete cervical dilation and head near the exit of the small pelvis, near the pelvic outlet. Yes, exit, they told you. No, more better to say pelvic outlet. And what they say you about the localization of the fetus head? Sagittal suture in the direct diameter, in the anterior, posterior diameter of the plane of the pelvic outlet, and small crown, they mean small fontanella close to the pubis. They told you that sagittal suture in the anterior posterior diameter of the pelvic outlet. If you remember mechanism of labor, it happened when the fetus is on the pelvic floor, and appear such condition. End of the second stage of labor, fetus head in the pelvic cavity, and due complication, it is fetal distress, bradycardia. And I told you that we need immediately, we need to have the immediate management. That's why use of obstetric forceps. No, not right. Obstetric forceps, cavity forceps, also it is obstetric forceps. Usually more better to say, and to my mind in KROK they change use of outlet forceps, low forceps. Yes, if low forceps, if the fetus head is on the pelvic floor. Cavity forceps, according to new protocols, we cannot use it all. But maybe the situation when the fetus stay in the middle of the pelvis and no any way outside, and to the abdomen cavity also no way. And only we can do to apply this cavity forceps. But in this case, the fetus head is on the middle of the pelvis, they describe you, and sagittal suture in oblique size of the plane of the narrow part of the pelvis should be. That's why here we have conditions for this operation: total dilation of the cervix, fetus head is on the pelvic floor, and indications: it is fetal distress, arrhythmia, and decrease of heartbeat. Yes, cesarean we cannot perform because all fetus head in the cavity of the bony pelvis, in the small pelvis, we cannot extract it fetus with the help of cesarean. Labor stimulation gives us aggravation of the condition of the fetus and even death if we wait. Yes, craniodermal forceps now we don't use. And I even don't, if you're interested, you can look through the our test books, and you will take this information. But usually there is no this craniodermal forceps at all. Yes, cavity forceps, no, because it has head on the pelvic floor. And that's why only, no, here need to be not obstetrical forceps, but outlet forceps or low forceps. Yes, cavity forceps we name cavity, atypical, or high forceps. Here typical forceps need to be, guys. That's why maybe different, no, maybe we will solve the test and we will need this condition. Yes, but you need to remember, very attentively read the test, pay attention. If we have change of the condition of the fetus, usually it is indication for forceps or cesarean, but it is they pointed in every test where fetus head, in the pelvic cavity and sagittal suture direct diameter, it is anterior-posterior size of the pelvic outlet. We have, and we apply forceps if the fetus head only engaged or pressed to the pelvic inlet. You think about that cesarean section. It depends on localization. In the cavity, forceps, above the cavity or slightly engaged, it is cesarean section. And again, I remind you this condition when we speak about the operation. I plan to show you operation and very specific technique, and we again return to this question. Так, thank you, Suresh. Swain, please read the test.
A 40 weeks pregnant woman in intrinsic obstetric investigation, the cervix of uterus is undeveloped. The oxytocin test is negative. Upon inspection at 32 weeks, it is revealed that atrial pulse is 140/90, proteinuria 1 gram per liter, and peripheral edemata. Reflexes are normal. Choose the most correct tactic of the guiding guiding the pregnant. So the answer is labor stimulation after preparation.
Yes. Why now 40 weeks of gestation? Yes, woman
Yes.
has. And we know that at 32 it was BP 140/90, protein in urine 1 gram, and edema. It is what stage of preeclampsia?
It is mild form.
Yes, mild form of preeclampsia. But I don't know why they give you at 32 weeks. What happened at 40 weeks? No, now what problem we have? 40 weeks of gestation, preeclampsia, and cervix underdeveloped. What does it mean, underdeveloped cervix?
Cervix is not dilated.
Yes, you're quite right. You understand this, but more better to say cervix immature is not mature according to Bishop's score. If you remember this Bishop's score, yes, it's not open, it's not soft. Yes, and what we need to do? Yes, why we don't perform cesarean? Can you explain me? No, we have mild preeclampsia. I don't know why they give you this 42 weeks. Mild preeclampsia, yes? Why we don't indicate it bed regimen for 1 month? Can you explain me?
Teacher, it is already 40 weeks pregnant.
Yes, you understand this. Thank you. Yes. It's maybe, yes, cesarean section immediately, but we don't know exactly what is the condition of the woman. Yes, mild preeclampsia is not really strict indication for cesarean section. Severe preeclampsia without effect of the treatment. And eclampsia, of course, it is indication for cesarean. Here, mild preeclampsia, but cervix is not developed. That's why we prepare the cervix. No, you need to remember this. Underdeveloped cervix or immature, they can tell you, or can give you, and labor stimulation. Why? Because mild preeclampsia is not indication just to immediate cesarean. Yes, understand, guys? Severe preeclampsia, then eclampsia, it is cesarean for, again, guys, I told you and strongly recommended to remember this classification, and according to situation, you can solve the test. If you know this, not a lot, some moments, yes, where you need to remember this. Then, and in KROK test, I need the test when they give you mild, severe, eclampsia, and from all these options, you need to choose the right diagnosis. That's why it's very significant to know classification of preeclampsia. Так, and
Teacher,
number, yeah.
Teacher, what does it mean oxytocin test is negative?
Oxytocin test negative. It's maybe. You see 40 weeks of gestation, but cervix immature, yes? And usually it is test which we perform to pregnant woman in order to know is uterus ready for labor. When we introduced one, we perform intramuscular injection of oxytocin, yes, intramuscular. And usually if the uterus sensitive and ready for labor, we can see answer of the uterus. Uterus begin contracted. All this we do under control of cardiotocography and look to the reaction of the uterus, perform this intramuscular injection, and if uterus is ready, we see the answer, begin the contractions of the uterus, and then we make the measuring of these contractions and amplitude of these contractions, and according to this, we see the changes of the fetal heartbeat with the help of cardiotocography. If oxytocin test negative, it means after this injection, no any reaction of uterus, yes? It's very specific for post-term pregnancy. Uterus is not sensitive. Yes, maybe due to hormonal disorders, it can happen. Infantilism maybe, and uterus is not answer on this oxytocin which we give to the in order to stimulate contractions of the uterus. In this case, it is negative. That's why we need to prepare woman. Usually how we prepare? With the help of drugs, with plants which make the cervix mature, or it's maybe laminarias. No, I never see the very good effect. Usually we use folliculin. Folliculin, it is hormonal drugs and with the help of these injections, we make the cervix and uterus more sensitive to oxytocin. And we prepare the cervix and then indicated stimulation of labor. Here, oxytocin test negative means that uterus at all is not answer on oxytocin, is not so good. That's why we need to prepare this woman and indicated stimulation of labor. If something happened, we stop to stimulate labor. For example, preeclampsia of mild state transformed to severe preeclampsia. In this case, we at once begin cesarean. Understand, guys? Yes? Так, who? It is was preach. Yes, Salim, please read the test.
Yes. 30-year-old.
Yeah. Salim, I don't hear you.
Hear me now?
Now here, yeah.
Yes, labor activity began 6 hours ago. Uterus was in higher tonus. Head of the fetus is above the opening into the small pelvis. Fetal heartbeat is 136 per minute. PV cervical dilation is 4 centimeter. Uterine forces is spasming at a height of peridynia. Head is level with opening into the small pelvis. It is pushed off. What is the most probable diagnosis? It's discoordinated because it's hypertonus of the uterus, right? Uterus is a higher tone, and the fetus is also opening into the small pelvis. Those are clinical signs of discoordinated labor activity.
Guys, yes, my dear, what we have, do you remember? Uterine force, they mean cervix, yes? Uterine
Yes.
force. Uterine force spasming at a height of paradynia. What in normal need to happen? Uterine relax at the height of paradynia, but
Yes.
paradynia, it is contractions of the uterus. At the height of the contraction, yes? Of the uterus. And here we have spasm. And I told you about this test. It is the sign of discoordinated labor, yes? Acute pain also possible for discoordinated labor. And usually this is the key for this sentence. At the height of the paradynia, spasm of the uterine fossa or cervix, yes, for uterine ostium. It is the sign of something wrong in bad labor activity. Yes, cervix needs relax, but not spasm, not contracted. Number 6, and please need here read the test.
24-year-old Primipara was hospitalized with complaints of discharge of the amniotic waters. The uterus is tonic on palpation. The position of the fetus is longitudinal. It is pressed with the head to pelvic outlet. Palpation of the fetus is rhythmical, 140 beats per minute. Auscultated on the left below the navel. Internal examination. Cervix of the uterus is 2.5 centimeter long, dense, and external os is closed. Light amniotic waters out of it. Point a correct component of the diagnosis.
Mhm.
The amniotic waters are out of it, and the external os is closed, so it is antenatal discharge.
Yes, thank you. Closed amniotic sac, no labor activity. Yes, external was closed, of course. No, 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 no. I don't want to add anything. Thank you. The next number 7, and Eutemia, please read the test.
A woman of 34 years old, it is her 10th labor at full time. It is known from the anamnesis that the labor started 11 hours ago. Labor was active, painful contractions, started after discharge of waters and became continuous. Suddenly, the parturian got knife-like pain in the lower abdomen and labor activity stopped. Examination revealed positive symptoms of peritoneum irritation, ill-defined uterus outlines. Fetus was easily palpable, movable. Fetal heartbeats wasn't auscultable. What is the most probable diagnosis? It is rupture of uterus.
And evidence signs, it is what?
The evidence signs are that the what is this? The labor activity stopped,
Yeah.
and that the fetus was easily
Yes,
palpable.
easily male peritoneum irritation. We have a lot of signs here which showed us that it is the rupture of the uterus or hysterorexis. Thank you. Так, the next, please, Ashit Mahanti. Mhm. Yes, guys, why it is pathological? Give me the main signs of this pathological preliminary period in this case. Yes, you're quite right. Preliminary period can last it not more than 4 hours. We have here 36 hours, yes, but maybe they give you primary uterine inertia, cervix dystocia, physiological preliminary period. Yes, what are the main signs of preliminary period? Not beginning of labor. It is irregular labor pain, irregular. Labor, regular pain, preliminary irregular, and lasted for a long time, 36 hours, woman child, yes? It is pathology, of course, yes? You have the test when they describe you and write answer pathological preliminary period. Then what else we have? We have immature cervix according to Bishop's score. It is a long cervix, 3 centimeters, it is 3.5 normal size of the pelvis. Consistence of the cervix, dense, and retroflexion, it's not right, my dears, retroflexion. We can see only in the case when we have the uterus in retroflexia. It means what they mean. No, it's not right. I don't agree with this. The cervix turned to the sacrum area, to the sacrum. It is all signs of immature cervix. If cervix mature, it occupies central position in the pelvic, soft, and begin effacement of the cervix, and cervix become possible for the finger or even 2 fingers sometimes. Yes, all signs of immature cervix. Yes, irregular labor pain, it is preliminary, prolongation 36 hours. Yes, of course, it is pathological preliminary period, and sometimes they ask you what to do, not diagnosis, but what to do. In this case, right answer it is cesarean. Usually it happened if we have postpartum pregnancy and different complications of pregnancy. Так, thank you. It was Ashit, yes. Так, Vilimva absent, yes. Так, Singh, please read the test.
Secondary para has regular birth activity. 3 years ago, she had cesarean section for the reason of acute intrauterine hypoxia. During peritonia, she complains of extended pain in the area of post-surgical scar. Objectively, fetus pulse is rhythmic, 140 BPM. Vaginal examination shows 5 centimeter cervical dilation. Fetal bladder is intact. What is the tactics of choice? Cesarean section.
What we have here? What is the diagnosis here? What in the history of the patient we have?
She had a cesarean section and now she had scar on the
Yes.
cesarean.
Yes, and she has extended pain. What we have, it is the risk of the rupture of the uterus in the area of post-surgical scar. It is very frequent situation, yes. No, statistic, if we speak about the statistic, yes. And it is risk of the rupture of the uterus. That's why we have the history, we have the pain in the area of post-surgical scar, and birth activity. Our management need to be immediate. We perform cesarean section. Then, guys, we have 9 minutes, and we'll meet with you at again at 10 and 50. At 10 and 50. Now we have the minutes, and that's why it was Shanil, yes? Shanil, please, Navjot Singh, read the test. Aulak, секунде пара.
It's done.
Number 10, excuse me.
3-week tracts candidize 28-year-old tractions are very active. Retracting ring is at the level of navel and the uterus is hypertonic in form of hourglass. And on auscultation, the fetal heart sounds are dull. Heart rate is 100 per minute. Arterial pressure of parturient woman is 130/80. What is the most likely diagnosis? It's the risk of hysteroxis.
Hysteroraxis, it is what? Navjot, it is what?
Uterus rupture.
Yes, uterine rupture. What is the science?
There is a
I don't hear you, my dear.
Teacher, there is uterus is hypertonic,
Yeah.
right? And there is
Guys,
a
but hypertonic may be only risk of labor. Again,
yes,
retraction
teacher, but
ring. Do you remember?
there is
Ring
a
which
retraction ring.
at the level of the navel. Retraction ring
Right.
need to be in the lower part of the abdomen. It is a visible ring if the woman, of course, is not so fat, which divided more thick part of the uterus from the low segment. Yes, which transform isthmus of the uterus. Yes, and usually low. And if it is on the level of the navel, high. I told you. Yes, I show you what form of the uterus, hourglass, yes? And we have here the signs of suffering of the fetus, yes? Fetal distress, fetal heartbeat, dull 100, yes? And that's why, what we need to do, if I ask you, what we need to do here, think. If it is risk of hysterexis, what we immediately need to do?
Uh, Teacher, we
Guys,
have to do like cesarean section.
of course, they can ask you about the diagnosis, can ask you about the management. If we see the signs of risk of the rupture of the uterus, of course, it is cesarean. And the last one, and we will make the break. Please, Kunya, read the test.
A 30-year-old multigravida has been in labor for 18 hours. 2 hours ago, the pushing stage began. Fetal heart rate is clear, rhythmic, 136 per minute. Vaginal examination reveals complete cervical dilation, fetal head in pelvic outlet plane, sagittal suture in line with obstetric conjugate. The occipital fontanelle is near the pubis. Patient has been diagnosed with primary uterine inertia. What is the further tactics of labor? Outlet forceps. This is the same question.
No, not so the same. We have weakness in this case. At first it was fetal distress. Here we have uterine inertia. Yes, but I surprised because they said the diagnosis at the end of labor. Usually labor prolong 18 hours. Here need to be secondary inertia, guys. You need to understand this. At all, I don't know. 18 hours of labor, and only when the fetus head occur on the pelvic floor, they speak about the primary uterine inertia. Of course, it should be secondary uterine inertia, not primary. Of course, outlet forceps, because fetus head is on the pelvic floor. Yes, and these forceps we need to perform due to weakness of labor, but not, I don't agree with primary inertia at all. They confused you with these questions. Guys, and outlet forceps. No, uterine inertia, if you see, and the fetus head in the cavity of the pelvis near the pelvic outlet, it is, of course, outlet forceps. Pelvic outlet, outlet forceps, keywords, and primary uterine inertia. Remember about it. Now, I stop my demonstration, and I told you we will meet at 10 and 50, guys.